All right, we're on part C now of this autonomic nervous system lecture, picking up back up with sympatholytics, or the beta adrenergic blockers. The short way of saying it is beta blockers. So these block the sympathetic nervous system, the stimulation of the beta adrenergic receptors. It competes with norepinephrine and epinephrine. Remember, those are the sympathetic agonists. And it can be selective or non-selective. I mean, cardioselective is beta 1, and beta 2 would be respiratory selective. These are catecholamines. They promote glyconeogenesis. This is the production of glucose from glycogen and metabolize glucose in response to hypoglycemia. So beta blockers impair the secretion, which causes an elevated blood glucose level. So if you're giving beta blockers, you need to watch for high blood sugars. Beta 1 effect, again, beta 1 is the heart. So beta 1, we have one heart. Beta 2, we have two lungs. Easy way to remember that. Some common beta blockers are Inderal or propranolol. Coreg is the brand name for carvedilol. Normodine is the brand name for labetalol. Olol, O-L-O-L. Not outstanding, laughing out loud, or whatever you want to do it. But if it ends in O-L-O-L, you're looking at a beta blocker. The cardioselective, see, those first ones are non-selective, so they affect beta 1 and beta 2. The cardioselective beta blockers, which affect just the heart, lopressor and toprol, which are brand names for metoprolol. Tenormin is a brand name for atenolol, and those are the two most common ones you'll use. So, why do we use beta adrenergic blockers or sympatholytics? For angina, chest pain, anti-anginals, beta blockers work very good for that. It decreases the demand for myocardial oxygen, cardiac muscle. It's cardioprotective, so a person who's had a heart attack, very frequently they will be immediately put on beta blockers to help protect the heart from further damage. It can be used to treat dysrhythmias. It can treat high blood pressure. And it treats high blood pressure by lowering the heart rate. Migraines. Many people use these for migraines. Glaucoma, topical drops for glaucoma. And some of these can also treat congestive heart failure. Side effects. There's a lot of side effects here, and the most serious undesirable effect is caused by the acute withdrawal of the drug. So if you're taking a beta blocker for a long time, you cannot just stop it. You have to be weaned off of it so that your body gets used to it. What are some contraindications? Well, if they're certainly allergic to the drug, you can't give it. That's pretty basic. If they have uncompensated heart failure, heart block or bradycardia. A heart block is a specific condition where the electrical system of the heart is not functioning. So you get slower rhythms that are symptomatic and can cause a lot of problems. Severe pulmonary disease can be worsened with this. Raynaud's disease. And there's an additive effect when they're given with other medications. So when you're giving these, you will always take an apical pulse. And where do you find the apical pulse? Is it? No, it's carotid. It's radial. Apical, you have to listen for the apical pulse. You will always contact the physician if their pulse is under 60 or their blood pressure is under 100. Some places, some doctors want a contact if it's under 50, but generally it's under 60 pulse, under 100 systolic blood pressure. If they have a weight gain of more than 2 pounds or more in a day, or 5 pounds or more in a week, that's significant. And then we're looking at congestive heart failure problems. Any shortness of breath that is increasing, they should always change positions slowly. Remember, these can cause orthostatic hypotension, low blood pressure. So some of the Nursing implications, we're always going to assess for allergies like we do with everything. We're going to look for COPD, chronic obstructive pulmonary disease. We're going to ask if they've ever had episodes of hypotension or bradycardia. Bradycardia, slow heartbeat. That's the opposite of tachycardia. Congestive heart failure, or they've had a history of dysrhythmias. Alpha blockers, again, may precipitate hypotension. Beta blockers may precipitate bradycardia, as well as hypotension, heart block, congestive heart failure, and bronchoconstriction. Remember, bronchoconstriction, a beta blocker can actually cause bronchoconstriction, and that is, if a person has asthma, you want to use a beta blocker very carefully. And always monitor for side effects. Client teachings, we're never going to stop medications abruptly. If they have constipation or urinary hesitancy or bladder distension, report that. We're going to notify the physician about the weight gains, of course, shortness of breath, edema or swelling of the feet or ankles, any syncope, dizziness. We talked about that last week in class. Okay, let's talk about the parasympathomimetics, the cholinergics. So these stimulate the parasympathetic nervous system. They mimic the action of acetylcholine. And these address the cholinergic receptors, the nicotinic and the muscarinic receptors. The cholinergic receptor is determined by location and the action once it's stimulated. So nicotinic receptors, they're located in the ganglia of both the parasympathetic nervous system and the sympathetic nervous system. They're named nicotinic because they also can be stimulated by the alkaloid nicotine. So let's think about that a little bit. People who smoke, this stimulates the parasympathetic nervous system. The muscarinic receptors are located postsynaptically after the synapses in smooth muscle and cardiac muscle, and it begins it's named muscarinic because it's stimulated by the alkaloid muscarine. Now, at recommended doses, these primarily affect the muscarinic receptors, but at high doses, it hits the nicotinic receptors. There are many undesirable effects due to the stimulation of the nicotinic receptors. So these are direct-acting cholinergic agonists. Remember, an agonist causes a reaction. They bind to those receptors and they activate them. Indirect-acting cholinergic agonist binds to cholinesterase. Remember, ACEs are enzymes. So if it's direct-acting, it's going to activate the cholinergic receptors. Indirect binds to cholinesterase, which makes more acetylcholine available at the receptor sites, because cholinesterase breaks down acetylcholine. The drug effects, it stimulates the intestine and bladder, gastric secretions, GI motility, urinary frequencies. It constricts the pupil. It reduces intraocular pressure. It increases saliva and sweating. So what are some of the direct-acting agents? Well, pilocarpine, succinylcholine, and barbitol are common. The indirect acting are the physostigmine, the pyridostigmine, neostigmine, and edrophonium. I've never given edrophonium. Why would we use these? Well, for the direct-acting agonists, especially pilocarpine, is used as a topical eye drop, and of course that's used to reduce intraocular pressure in patients who have glaucoma or who are undergoing eye surgery. Bethacol, or urocholine, is used to increase bladder and GI motility and relaxation. Indirect, the neostigmine, the edrophonium, these cause skeletal muscle contraction. These are used to diagnose and treat myasthenia gravis, or MG. It reverses neuromuscular blockade, And donezepam, or Aricept, increases acetylcholine in the brain, which helps to improve memory and learning capabilities and the treatment of Alzheimer's disease. Some other drugs that treat Alzheimer's is tacrine, or Cognex, rivastigmine, or Exelon, commonly used as a patch, and galantamine, or Remenil. Aricept and Exelon are very commonly used, especially with patients who have varying levels of dementia. Side effects are almost always the result of overstimulation. So when properly used, the side effects are controlled. Too high of dosing will cause the side effects. In the heart, bradycardia, slow heart rate, hypotension, AV block, and cardiac arrest. That's a bad one. Central nervous system, headache, dizziness, convulsions, and you can see the whole list on that slide. As always, a known contraindication or known drug allergy is obviously a contraindication. Somebody who has bradycardia or hypotension, or COPD, or epilepsy, Parkinson's, or hypothyroidism, you're just not going to take these. It will only make those conditions worse. Nursing implications. Well, like always, we're going to assess for allergies. We're going to look for the presence of GI or GU obstructions. Asthma, peptic ulcer disease, coronary artery disease. We'll always get a baseline set of vital signs before administering medications, always. Donezepam, Aricept, you may not see any therapeutic effects for up to 6 weeks. How do we treat overdosing on cholinergics? Atropine. Atropine increases the heart rate. You always monitor for therapeutic effects. You're going to look for reduction in the signs and symptoms of myasthenia gravis. You hopefully will get increased bowel sounds. You'll hopefully start passing flatus, have bowel movements, and urination should occur within 60 minutes of Bethanechol administration. So those are things you need to remember. Bowel sounds, big deal. Heart rate, big deal. Now, what about the parasympatholytics, or the anticholinergics? Remember, these are the opposite of a cholinergic. These block or inhibit the actions of acetylcholine in the parasympathetic nervous system. And these act at the muscarinic receptors. Cholinergic blockers have similar effects as adrenergic. Because remember, if you stimulate one, you reduce the other. If you do reduce one, you stimulate the other, or it has the same effect as stimulating the other. These are competitive antagonists, and they have a very narrow therapeutic index. Once these drugs bind to their respective receptors, they inhibit nerve transmission at those receptors. So that's how they function. Atropine is the most common anticholinergic drug. It's used for mostly cardiovascular problems, bradycardia and second-degree heart block. Atropine makes the heart more prone to stimulation. Belladonna is another one. Glycopyrrolate or Robenul